You can feel completely fine right now. No chest pain, no shortness of breath, no arm going numb, while your heart has been quietly failing for the last 6 months. Not might be failing, is actively. And the evidence is sitting in your ankles, in plain sight, in the form of 5 specific signs that most people have been told are just aging, or standing too long, or yesterday's sodium. I'm going to walk you through all 5 of them, from the mildest and most easily dismissed to the one that should end your afternoon and start a medical conversation this week. At the end, I will give you a named protocol, the ACE protocol, that cardiologists use during cardiovascular exams and that you can replicate in 90 seconds in your own bathroom. I'm naming it now so you keep that promise in the back of your head until we get there. Assess, compare, elevate. That's all it is. But the reason it works is in the biology I'm about to explain, and you need the biology to understand what you're actually looking at. I'm Carol. I read clinical guidelines, meta-analyses, and cardiology textbooks, so you don't have to. And today I want you to actually look at your ankles, not glance at them, because the 5 signs I'm about to describe are not folk medicine. They are clinical diagnostic markers documented in cardiovascular literature, taught in medical school physical examination training, and almost never communicated to patients in a form they can act on. Let's start with why the ankle is a cardiovascular monitoring station in the first place, because the biology is not obvious, and understanding it is what makes everything else in this video click into place. Your circulatory system is a closed hydraulic circuit. Closed means it has no external outlet. All the fluid that leaves the heart through the arteries must return through the veins. The heart is the pump that maintains the pressure differential, keeping this circuit in motion. Arteries are the high-pressure delivery side. They carry oxygenated blood outward at significant force like pressurized pipes in a building's supply system. Veins are the low-pressure return side. They carry blood back to the heart more slowly, aided by the muscular contractions of movement and a series of tiny one-way valves inside the veins that prevent backsliding between beats. Your ankles are the lowest point in this entire circuit. Gravity works against the return side. Every waking second you are upright. The heart must generate enough pumping efficiency to overcome that gravitational pull and drag the blood back up from the bottom of the system. When the pump is functioning well, this is effortless. The system is balanced. But when the pump starts to lose efficiency, when output drops even modestly, even below the threshold of symptoms you would recognize as alarming, the first place that imbalance becomes visible is the lowest, most gravitationally compromised point in the network. The ankle is not the problem. The ankle is the warning light at the bottom of the pipe. The invisible villain in this story is called subclinical cardiac dysfunction. Subclinical means below the threshold of noticeable symptoms. Cardiac means heart. Dysfunction means the pump is underperforming. Put it together, a heart that is not working optimally in ways that haven't yet produced recognizable symptoms, but that is already producing measurable physical changes at the extremities. The specific form of this dysfunction that most often goes undetected is heart failure with preserved ejection fraction. The ejection fraction is the percentage of blood the heart ejects with each contraction. It measures pumping efficiency. In standard heart failure, the ejection fraction is reduced. The muscle is weak and doesn't squeeze hard enough. But heart failure with preserved ejection fraction is different. The heart squeezes adequately. The problem is that the chamber walls have stiffened and the heart doesn't fill properly between beats. It cannot handle high circulatory demands, and over time, pressure backs up through the entire venous return circuit. The return pipes become congested. Fluid accumulates at the bottom of the system first. Heart failure with preserved ejection fraction now accounts for approximately 50% of all heart failure cases in developed countries, according to the American Heart Association. It is more prevalent in women than men. It is strongly associated with age over 60, with a history of high blood pressure, and with metabolic syndrome. And it is notoriously underdiagnosed because the standard cardiac ultrasound, the echocardiogram, often looks normal, since the ejection fraction is technically preserved. You need different indices, different measurements to catch it. Many primary care offices do not run those indices unless specifically requested. And the first physical sign in a significant percentage of cases is ankle swelling that the patient attributes to being on their feet too long. But we're getting ahead of ourselves. The countdown starts at 5 and ends at 1, and they are ordered that way deliberately. Sign number 5, the disappearing leg hair. Look at your lower legs right now, from the knee down to the ankle. If you are a man, you have probably never in your life paid conscious attention to the hair on your lower legs. If you are a woman, you may have dismissed any absence of hair there as the long-term result of shaving or aging or where your socks sit. Here is what I actually want you to look for: a visible demarcation line somewhere between mid-calf and the ankle, below which the skin is noticeably smoother, less hairy, sometimes shinier, sometimes slightly different in texture or color than the upper portion. Not sparse, significantly absent. Most people who notice this assume it is nothing. It is not nothing. Hair follicles are among the most metabolically demanding structures in skin. Each one requires a dedicated capillary blood supply to sustain its growth cycle. When the arterial blood supply to the lower leg drops below a threshold that can sustain that cycle, which happens when the arteries supplying the legs start to narrow due to the buildup of fatty plaques inside their walls, the follicles don't receive enough oxygen and nutrients to continue growing. They don't die. They stop. The skin below the narrowing becomes progressively hairless, sometimes shinier, sometimes thinner, sometimes slightly cooler to the touch. In more advanced stages, it can develop slow-healing sores that people mistake for minor injuries from footwear. This is peripheral artery disease in its early visible stage. Peripheral means outside the heart. Artery disease means the delivery pipes are getting clogged, and the mechanism linking leg arterial disease to cardiovascular risk is not that the leg problem travels to the heart. The mechanism is that atherosclerosis, the plaque buildup process, is systemic. It is happening in the coronary arteries, feeding your heart muscle, at the same time it is happening in the femoral artery, feeding your leg. It is happening in the carotid arteries, feeding your brain, at the same time it is thinning the skin above your ankle. The leg shows signs first because those arteries are smaller and because gravity means blood has to work hardest to reach that point. Research published in literature associated with the American Heart Association consistently shows that people with confirmed peripheral artery disease have 2 to 6 times the risk of heart attack or stroke compared to age-matched individuals without it, not because the leg problem causes a heart attack, but because both are expressions of the same underlying disease running simultaneously through the same arterial system. The clinical test for this is called the ankle brachial index. Blood pressure is measured at the ankle and at the upper arm, and the ankle reading is divided by the arm reading. In a healthy arterial system, both readings should be close to equal, producing a ratio above 0.9. When plaque narrows the arteries to the leg, blood pressure drops below the narrowing and the ankle reading falls. A ratio below 0.9 indicates peripheral artery disease. Below 0.5 indicates severe arterial compromise. The test is painless, takes about 5 minutes, and can be done in any primary care office. It is not routinely performed unless requested. You can ask for it by name. If you are over 60 with any combination of smoking history, elevated cholesterol, high blood pressure, or diabetes, you have a reasonable clinical basis for requesting it. According to the American Heart Association, peripheral artery disease affects 8 to 10 million Americans. In adults over 60, roughly 1 in 5 has some degree of arterial narrowing in the lower limbs. The majority of those people have no pain, no classic cramping, no textbook symptoms, just thinning skin below the knee that they have never been told to take seriously. Sign number 4, the rust stain that won't wash off. On the inner side of your ankle, near the prominent bony bump on the inside, which anatomically is called the medial malleolus, look for a brownish, reddish, or orange discoloration of the skin. It may look like an old bruise that faded yellow and never fully disappeared. It may look like a splotchy, uneven tan restricted to one small area. It may have been there long enough that you have stopped registering it as something new because it developed gradually over years and the change was imperceptible month to month. This is called hemosiderin staining. The biology behind it is specific, and it tells you something important about what the venous return circuit has been going through. When pressure inside the venous system is chronically elevated, when the return pipes are carrying more load than they were designed to sustain, the walls of the tiny capillaries at the very bottom of the circuit begin to fail, not catastrophically, microscopically. Individual red blood cells pass through capillary walls into the surrounding connective tissue. Once outside the bloodstream, those red blood cells begin to degrade. The hemoglobin molecule inside each one, the iron-carrying protein that makes blood red, gets broken down by the body's cellular cleanup enzymes, and the iron component of that degradation gets deposited permanently in the tissue as hemosiderin. Hemosiderin is, at the molecular level, iron oxide. It is rust, deposited directly in the skin of your ankle. It does not wash off. It does not fade significantly over time. It is a record. And this is the part most people don't realize. By the time you can see it, the tissue has already been under abnormal pressure for weeks, months, or in many cases years. You are not looking at the beginning of a problem. You are looking at the accumulated evidence of how long the problem has been running. The condition associated with this staining is called chronic venous insufficiency, meaning the tiny one-way valves inside the leg veins have lost their ability to seal properly between heartbeats, so blood slides back down instead of moving steadily upward. Venous pressure in the lower leg chronically rises. The capillary walls fail. The rust accumulates. Chronic venous insufficiency can be a purely local structural problem, varicose veins, valve damage from a previous clot, but it can also be a downstream consequence of elevated central venous pressure caused by cardiac dysfunction. When the right side of the heart struggles to receive and process venous return efficiently, that backup propagates through the entire return circuit. The valves in the leg veins didn't necessarily fail independently. The system behind them may have been pushing back too hard for years. A 2016 study in the journal Phlebology found that chronic venous insufficiency with visible skin changes, including hemosiderin staining, is present in approximately 40% of people over 65. And in a meaningful subset of those patients, the venous insufficiency was the first detectable external marker of underlying right-sided cardiac stress, appearing before any formally recognized cardiac symptoms. Sign number 3, the temperature test. Both hands, back of the fingers pressed flat against the top of each ankle simultaneously for 5 full seconds. The backs of the fingers, not the fingertips, because fingertip temperature sensing is blunted by the higher density of nerve endings there. Hold them both for the same duration and compare. Both ankles should feel roughly the same temperature, not identical. There will always be small variation, but comparable. Warm, matched, consistent. What you are looking for is an obvious, meaningful discrepancy. Cold asymmetry. One ankle noticeably colder than the other points to an arterial problem on that side. Arterial blood arriving at the ankle carries warmth from the body's core. When arterial flow is reduced by plaque narrowing, the volume of warm blood arriving per unit of time decreases, and the surface temperature of the skin drops accordingly. The degree of cooling roughly correlates with the degree of arterial compromise. Mild narrowing produces mild cooling. Significant narrowing produces a limb that feels cold even in a warm environment. What cold asymmetry tells you is that the atherosclerotic disease process, which is again a systemic process, not a local one, has progressed further on one side of the arterial network than the other. The coolest ankle points to the most compromised arterial segment, the way a building's lowest water pressure identifies the wing with the most corroded pipes. Warm asymmetry is a categorically different clinical signal. One ankle noticeably warmer than the other, especially if that same ankle is also swollen, is one of the cardinal signs of deep vein thrombosis, which means a blood clot forming in the deep vein of that leg. A clot creates a physical obstruction in the return pipe. Blood and fluid back up behind it. The body's inflammatory response to the clot, which is attempting to dissolve it, generates local heat. The skin over the affected area becomes warm, sometimes tense, sometimes faintly red. There may be a dull ache in the calf that doesn't respond to stretching, often described as a persistent cramp, or there may be nothing, no pain at all. This last detail matters enormously. In roughly 30 to 40% of deep vein thrombosis cases, according to clinical data, there is no pain and no tenderness. The clot is there, it is growing, the ankle is warm, and the person notices the warmth and files it under old injury still bothering me. The Centers for Disease Control and Prevention estimates that deep vein thrombosis and its direct complication, pulmonary embolism, a clot that has traveled to the lungs, together contribute to approximately 100,000 deaths in the United States each year. That is not a rare scenario. And after 60, the risk factors for clot formation converge in a way that simply does not happen at younger ages. Reduced cardiac output, slowing venous return, reduced mobility, elevated levels of fibrinogen and other clotting proteins driven by chronic low-grade inflammation, and the routine use of medications, some for blood pressure, some for hormonal health, that can secondarily elevate clotting tendency in susceptible individuals. A warm ankle is not a reason to panic, it is a reason to make a phone call today. Now I want to stop here because this is the moment in this video where I need to address something about how heart disease warning signs have been communicated to most people and why that communication has left nearly everyone looking in exactly the wrong direction for exactly the right amount of time for the situation to become serious before anything gets done about it. We have been told consistently from health pamphlets, from wellness newsletters, from the messaging that fills doctors' waiting rooms, that the primary warning signs of heart disease are chest pain, jaw pain, left arm pain, and shortness of breath during exertion. These symptoms are real. When they occur, they matter enormously, but they are late-stage symptoms. They are the expression of a heart already under acute ischemic stress, a system already in crisis mode, already past the slow build-up phase. They are the alarm that sounds after the pipe has burst, not while it is corroding. A 2020 analysis in the European Heart Journal found that in patients later diagnosed with heart failure, clinically measurable physical signs, including ankle edema, lower extremity skin changes, and measurable reductions in exercise tolerance, preceded the formal cardiac diagnosis by an average of 2 to 3 years in the majority of cases examined. 2 to 3 years, during which those patients were living their lives feeling mostly adequate, noticing their ankles looked slightly puffy at the end of the day, and attributing it to aging. The American College of Cardiology's own clinical guidelines explicitly include physical examination of the lower extremities, assessment of edema, skin changes, temperature, and peripheral pulses as a standard component of the cardiovascular exam. Standard, required. It is in the written guidelines. A survey published in the Journal of General Internal Medicine found that a substantial proportion of primary care physical examinations in the United States are abbreviated, and the detailed lower extremity assessment is frequently omitted. The instruction exists in the guidelines. The practice does not consistently match it, and the patient, who was never told to look at their own ankles, never asked. This is the part one find genuinely mildly absurd, rather than enraging. The information is there, it is in the cardiology literature, it is taught in medical school, and the gap between what is known and what reaches the patient is not a gap of science, it is a gap of communication, shaped by 9-minute appointment slots and a healthcare incentive structure that is far better at responding to crises than at preventing them. It's not a conspiracy, it is a math problem, and the way you solve it personally is by showing up to appointments already knowing what to ask for and what you have already observed. Before I walk through signs 2 and 1, which are the most clinically significant ones in this countdown, I want to address something about daily metabolic structure and vascular inflammation, because the connection is real and it's directly relevant to the kind of low-grade systemic pressure we've been talking about. I had read about circadian biology and intermittent fasting research for a long time before I actually built a consistent daily structure around any of it. My husband had actually done that work already. He spent months building a 30-day daily companion guide called the Noon Reset Protocol, based on the same Nobel Prize research on circadian rhythm that restructured how cardiologists think about morning metabolic risk. I bookmarked his research, I told him it was interesting, and then I continued doing it inconsistently for another 18 months because knowing something and having an actual daily structure that makes it automatic are genuinely not the same thing. That's on me. He built it after his own near fatal cardiovascular crisis, and it is careful, evidence based, and practical in a way that reading the studies is not. Results vary, and none of this replaces medical supervision, which I cannot stress enough. But the structure itself is sound. The guide is 2 pages per day, 1 page of science context, 1 page of structure and tracker, and takes under 5 minutes to use. It moves through 4 phases that map onto how the body adapts over 30 days. So you're not guessing why day 4 feels different from day 14. The piece I found most immediately useful was the breakfast meal section. 25 specific meal options with exact protein counts, because what you eat as the first meal after your fasting window is not a trivial decision. It either supports or undermines the metabolic work the fast period was doing. If you want it, it's through the link in the description for less than the cost of a restaurant meal. Now, back to your ankles. Sign number 2. The pit test. Press your thumb firmly into the skin on the inner side of your ankle or the top of your foot for 5 full seconds with meaningful pressure. Then release quickly and watch what the skin does. In healthy tissue, the small indentation disappears within a second. The tissue is elastic, fluid levels in the surrounding space are normal, and the skin springs back immediately. But when excess fluid has accumulated in the tissue, when the hydraulic circuit is forcing fluid into the surrounding interstitial space faster than the lymphatic system can drain it back, the thumb impression stays. It sits there. It fills back in slowly, over 3 to 10 seconds, sometimes longer, like a dent in wet clay that you have pressed your finger into. This is called pitting edema. The pit is literal. The mechanism behind it requires understanding something called Starling's forces of capillary exchange. At the level of the capillary, the smallest blood vessels in the body, where the actual exchange of oxygen, nutrients, and waste products occurs, fluid constantly moves in both directions. The pressure inside the capillary pushes fluid outward into the surrounding tissue. The concentration of proteins, specifically albumin, in the blood creates an osmotic pull that draws fluid back in. In a healthy system, these forces are roughly balanced and net fluid accumulation is minimal. When capillary pressure rises because venous pressure is backing up, because the heart is not generating enough forward momentum to keep the return circuit flowing freely, the outward push begins to exceed the osmotic inward pull. More fluid leaves the capillary than returns to it. The surplus accumulates in the interstitial space between the cells. Over hours, it becomes measurable. Over days, it becomes visible. The tissue becomes waterlogged, and when you press it, the fluid displaces under your thumb. When you release, it flows back slowly, leaving the impression. Here is the detail that most descriptions of pitting edema skip entirely, and that I think is one of the most diagnostically useful observations you can make at home. Cardiogenic pitting edema, edema driven by heart failure, has a characteristic daily pattern that is itself a clinical clue. It is typically at its worst at the end of the day after hours of upright posture during which gravity has been pulling fluid toward the lowest point of the circuit. It is at its mildest in the morning after a night of lying flat, during which the fluid has redistributed away from the ankles toward other body compartments. If you are noticing this pattern, significantly swollen ankles at 6 in the evening, noticeably less puffy after sleeping, that timing profile is clinically meaningful. It is consistent with gravitationally driven fluid accumulation from a systemic cause. Edema that does not follow this pattern, that is the same in the morning as in the evening, that does not improve with overnight rest or with elevation, points toward different mechanisms, including lymphatic system obstruction or low albumin levels from nutritional deficiency or liver dysfunction. The behavior of the swelling over a 24-hour cycle is diagnostic information that you can observe yourself and relay precisely to a physician. Bilateral pitting edema, both ankles simultaneously, is a classic and well-documented clinical sign of congestive heart failure. The word congestive literally refers to the congestion of fluid in peripheral tissues due to the heart's inability to sustain adequate forward flow. The American Heart Association reports that approximately 6.7 million adults in the United States currently live with some form of heart failure, with the majority of new diagnoses occurring after age 65. Among those patients, somewhere between 60 and 80% report having noticed ankle swelling for a period before seeking evaluation. The swelling was already there. They did not know what it was telling them. And the edema does not stay in the ankles indefinitely. As cardiac function continues to decline without intervention, the fluid front advances upward. What begins as ankle swelling progresses to lower leg swelling, then to thigh swelling, then to abdominal fluid accumulation called ascites, which you would feel as a sense of fullness or tightness in the abdomen. Then, eventually, to fluid around the lungs called pleural effusion, which is when breathing becomes difficult enough that something clearly has to be done. By the time the fluid has reached the lungs, the condition has been progressing for a significant period of time without detection. The ankle was the first readable chapter of that story, and it was legible the whole way through. Sign number 1. Asymmetric swelling. This is the most dangerous sign on this list, and the one most systematically misread. If you have one ankle that is noticeably swollen and one that is normal, and this is a persistent pattern, not a single occurrence after an unusual amount of walking, the cognitive error that catches most people is applying bilateral logic to a unilateral situation. Ankles swell sometimes, this must be one of those times. But bilateral swelling and unilateral swelling are physiologically different phenomena with different causes and different urgency profiles. Bilateral edema reflects a systemic change in pressure or fluid balance, the cardiovascular system, the kidneys, the lymphatics, something affecting both sides of the body equally because the cause is central. Unilateral edema means something has changed on one side only. And the list of conditions that affect only one ankle and are also harmless is considerably shorter than the list of conditions that affect only one ankle and are not. The most urgent concern is deep vein thrombosis, a clot in the deep vein of the affected leg. When the vein is partially or fully obstructed, blood and fluid cannot return efficiently from that leg. The ankle and lower leg on that side swell. The clot creates a local dam, and everything on the upstream side of it backs up. I described the warm asymmetry sign in sign 3, and this is where those two observations connect. Warm, swollen, and asymmetric is a combination that emergency physicians treat as deep vein thrombosis until proven otherwise by imaging. No single feature is conclusive. The combination is, after 60, deep vein thrombosis does not typically appear from nowhere. The cardiovascular environment produces it. Reduced cardiac output means slower venous return, which creates a more favorable condition for clot formation. Blood that moves slowly through a vessel is blood that is more likely to clot inside it. Chronic systemic inflammation, which is extremely common in people with the same metabolic profile that generates cardiovascular disease, elevates fibrinogen and several other clotting proteins. Reduced mobility, which often accompanies reduced cardiac reserve before the diagnosis is formally made, compounds this further. The clot is a product of the cardiovascular environment. It is not a random event. The second scenario for persistent unilateral swelling is structural vascular asymmetry, one limb with a more compromised venous or arterial architecture than the other. Atherosclerotic plaque burden is not perfectly symmetrical in the body. One carotid artery can be more occluded than the other. One venous valve segment can have deteriorated more extensively on one side. When the venous return from one leg is structurally disadvantaged relative to the other, from prior clot damage, progressive valve failure, or localized narrowing, that leg will swell preferentially and persistently, not dramatically, not necessarily with pain, consistently, just always a little more on that side. If you press both inner ankles simultaneously with equal pressure and one side creates a pit, that takes 8 seconds to refill while the other recovers in 1 second, that asymmetric response is a data point. It tells you that the hydraulic return circuit on that side has a structural disadvantage the other side does not share. That information belongs in a conversation with a physician, not in a search engine. The imaging test for this situation is a venous Doppler ultrasound, sound wave imaging of the deep and superficial veins of the affected leg. It is painless, widely available, does not require radiation, and is highly accurate for both clot detection and valve function assessment. You do not need a specialist to order it. You request it from your primary care physician with a clear, specific description of what you have observed: which ankle, how long, what the pit test showed, whether there was warmth, and whether the swelling changes overnight. That description will produce a different conversation than, "My ankle has been a little puffy lately." Now, the ACE protocol. A stands for assess, and the critical word is systematic. Every 3 to 4 weeks, in consistent lighting and at the same time of day, ideally in the morning before significant time on your feet, perform a full 5-point lower extremity examination. You look at hair distribution below the knee on both legs. You look at skin color and texture around the medial malleolus on both sides. You assess temperature with the back of both hands simultaneously, pressing for 5 seconds each. You perform the pit test on both inner ankles with equal pressure and equal duration, and you count the seconds until the pit refills on each side. Then you take a photograph of both ankles from above, from the same angle and distance each time. Put a small piece of tape on the floor to mark your foot position so the angle is genuinely consistent. The photograph matters because human perception adapts to gradual change so efficiently that you will not consciously register a slow progression without a visual baseline to compare against. The ankle that has been swelling incrementally for 6 months looks normal to you today. The photograph from 6 months ago will tell you a different story. C stands for compare, and there are two distinct comparisons to perform. The bilateral comparison is real-time and simultaneous, both ankles against each other, right now in every parameter: size, color, temperature, texture, pit recovery rate, hair distribution. Symmetry is the expected baseline. The cardiovascular system is designed to be bilaterally balanced. Any significant departure from symmetry means one side has a condition the other does not, and that condition has a cause that is worth identifying. The longitudinal comparison requires your photograph record, this ankle today against this ankle 3 months ago, 6 months ago. Progressive bilateral changes, both ankles gradually developing more pitting response, more hemosiderin staining, slower temperature recovery, represent a systemic and worsening process. A pattern of worsening over 3 observation points warrants escalating urgency, regardless of the absolute severity at any single point, because the trajectory is itself the clinical signal. A severely swollen ankle that has looked the same for 2 years is a different situation than a mildly swollen ankle that has been steadily worsening over that same period. E stands for elevate, and observe the response precisely. Lie flat on your back and raise both legs above the level of your heart, propped against a wall, elevated on a stack of firm pillows, whatever achieves roughly a 30 to 45 degree angle from flat. Stay there for 20 full minutes. Then look at both ankles and compare them to how they appeared before elevation. Rapid, meaningful reduction in swelling after 20 minutes of elevation. Ankles visibly less puffy. Pit test recovering faster. Is consistent with simple gravitational edema. The return circuit is functional. It just needed gravity removed from the equation to clear the backlog. Partial resolution suggests a return circuit that is working but under strain. Minimal or no resolution, ankles essentially unchanged after 20 full minutes of elevation above heart level, suggests a process that passive positioning cannot override. True lymphedema, in which the lymphatic drainage system itself is compromised. Severe cardiogenic edema, in which the volume of fluid has exceeded what positioning alone can manage. Or chronic structural venous failure with significant architectural damage to the return pathway. Document what you observe, not in memory. Write it down. 3 words: left ankle, response, timing. A sentence like elevation 20 minutes, left pit from moderate to mild, right unchanged, recorded 3 times across 3 months, is the kind of clinical history that changes how a physician responds to your call. It converts an anecdote into a data pattern. Physicians respond to patterns. The most common error people make with the ACE protocol is performing it once, finding something mildly concerning, deciding it's probably nothing, and not doing it again for 4 months. One observation is noise. 3 observations across 3 months are a trend. A stable finding over 3 months is reassuring. A worsening finding over 3 months, even if the absolute severity is still mild, is a pattern that warrants escalation. The trend is the information. The snapshot by itself is almost uninformative. If any of the 5 signs in this video are present when you look right now, and especially if sign 2 or sign 1 apply, or if any combination of signs applies simultaneously, you now have a vocabulary, a structured assessment, and the specific name of an imaging test to request. You are not waiting for the chest pain. You are reading the hydraulic circuit before it declares an emergency. I think about this often because it was exactly the situation my husband was in 8 years ago, a body sending signals through a system he had no vocabulary for, while he was too busy running a company to look. He nearly died. Doctors gave him a lifetime stack of medications and a general instruction to change his lifestyle, which I can tell you from personal experience watching him try to act on it, is approximately as useful as being told to learn to swim and handed the address of the ocean. We spent years learning how the cardiovascular and metabolic systems actually work after 50, what supports them, what erodes them, what the research actually shows versus what the wellness industry profits from you believing. And what I kept encountering over and over was information that was clinically real, peer-reviewed, and simply absent from the conversations most people have with their physicians, not because the information is being withheld, but because the standard of care was designed to respond to acute events and not to decode the slow, readable signals that precede them by years. The ankle is one of those signals. It costs nothing to look. It takes 90 seconds to assess properly, and it gives you access to information about your cardiovascular system's actual performance that most people never access, not because they don't care, but because no one told them the window was there. The information in your body is not a substitute for medical evaluation. It is the reason to seek one when the pattern warrants it. And it is the thing you bring to that appointment instead of, I don't know, my ankles have been a little puffy lately. If you are going to perform the ACE protocol today, assess, compare, elevate, comment ankles below so I can see who is actually doing this. And if this reached you when it mattered, subscribe. Not because the numbers matter, because this channel exists on the premise that the most dangerous health information is not wrong information. It is the right information that never got to you.